as you all know, it's a failure to initiate sustained breathing at breath severe enough to cause metabolic acidosis, neonatal encephalopathy, and multi-organ dysfunction. It's a major neonatal problem and contributes significantly to neonatal mortality and morbidity. It is third important cause for neonatal mortality in our country. Second, after prematurity and infection. So perinatal asphyxia contribute around 20% of India. In other words, around 2.5 to 3.5 lakh infants are dying each year due to birth asphyxia, and most of that occurring during the first 3 days of life. In addition, antepartum and interpartum asphyxia contribute to as many as 3 to 4 lakh stillbirths per year in India. So I really thank IAP Kerala under the leadership of visionary President Dr. Jairam sir for including this in his action plan. So without wasting much time, I hand over the mic to my colleague Dr. Prashant to proceed. Over to Dr. Prashant.
Good evening all. Today, the concept of preventing further ongoing reperfusion free radical injury post-asphyxia in the context of developing countries like India will be discussed in three parts today. So, coming to the speakers, first one is Vivek Raju, who is working as a consultant neonatologist in Koili Hospital, Kannur, and he has did his MBBS and MD from Calicut, and a DNB neonatology from KIMS Trivandrum, and Dr. Sreekanth, who has done his undergraduation and post-graduation from KMC Manipal and KS Hegde respectively, and DM from Kolanjeri Medical College. And Gokul Das completed his MBBS from Kottayam and MD from Calicut and a DM from JIPMER. Gokul Das and Sreekanth is working as consultant neonatologist in MIMS Kannur. So without wasting much time, I'm directly giving the mic to Dr. Vivek, who is the first speaker for today. Thank you.
Good evening all. Good evening senior members. Good evening colleagues. Hope I am audible. I think the slides are visible.
Yes.
So I'm little depressed here today because my topic was an introductory topic which contains basic details about current scenarios, but Narayan sir, Jairam sir and all has already described most of the details that are present in my slide. So I'm little confused what to tell now. So to begin with, we all know that birth asphyxia, as Nandakumar sir told, birth asphyxia is still one of the leading cause for neonatal mortality in India. So going to the details, like as we all know, India is still one of the major contributor to neonatal birth rate to the world population, like maybe 1/5 of total live birth globally is contributed still by our country. So whatever happens, whatever statistical change happens in our population, whether it's in a NMR, whether it's in MMR, whatever, perinatal mortality, whatever, it reflects a lot in the world statistics also. So everybody, basically we can say that everybody is looking into India, what is happening in India. So when we see the statistics, we know that 1/4 of the, unfortunately, as the global support from us, or the global proportion of global delivery rate or the live birth rate is very high in India. Of course, the majority of the neonatal mortality is also given by India. More than 1/4 of the neonatal mortality rate of the world is contributed by our country. So when one of the major causes, as we told, there are different causes like prematurity, infection complications, and one of the major causes asphyxia. So if we can cut one among them to a lesser percentage, we can see that it can create a lot of impact in the community, a lot of impact in the statistics, a lot of impact in the world statistics. So action in India becomes very important, unfortunately. So as per latest data, neonatal mortality, various sites are showing various data. UNICEF is showing 22 currently neonatal mortality. The 5th National Family Health Survey showed 13 as the neonatal mortality, but we know that Kerala is leading among them. It's 3.4 as per NFHS 5 in Kerala, neonatal mortality rate in Kerala. But the problem is when the Millennium Development Goal, they were targeting a reduction in under 5 mortality rate. The reduction in infant mortality and under 5 mortality went like a lot of reduction happened over this time from 2000 to 2015, but they couldn't produce that much decrease in neonatal mortality rate compared to infant mortality rate. So we can understand that still the major problems are there. This is the 2012 published in Lancet, a major study from India about the cost for neonatal mortality. You can see that preterm birth and complications are the leading one, but almost equal to infectious complications, intrapartum related complication, as Nandamar sir told, 20%, still it's there. So if you can reduce at least one, like a reduction in intrapartum related complications like asphyxia or neonatal encephalopathy, if you can reduce it to a certain level, it has a lot of impact in reduction in neonatal mortality rate also. So there are factors affecting incidence in our country itself, because we know that there is a regional difference, like northern states. When we calculate the world data itself, Rajasthan, UP, and Bihar and Madhya Pradesh can itself contribute to almost 1/3 of the neonatal mortality. So that much major difference is there among different regions in India itself. There is a lot of difference between rural and urban situations among communities, because the health-seeking behavior of different communities may be different. So even if you take in Kerala itself, there may be difference in district-wise difference will be there if you take the statistics. So there are gender differences, especially in the northern part of India. There are studies published because the average GDP that is spent by a family is more when a male child is being born. That is shown by studies in Uttar Pradesh and Bihar. So northern state gender differences are still there, and the incidence of asphyxia is directly related to per capita GDP, maybe because of their health-seeking character, because depending upon their income. So that may be the cause, as per capita GDP affects the incidence of birth asphyxia. And also obviously maternal health indicators like age of the mother. When it's less than 20, they have proven that in the cross-section of less than 20, intrapartum related complications are more. So these are the factors affecting incidence in various areas of India. So when we look for the prevalence in India, it is very difficult to assess, because majority of the cases may not be reported properly. There may not be a proper definition for neonatal encephalopathy or HAE. So it is very difficult. Whatever data available is an NNPD database that is published by AIMS WHO collaboration. That is 2.6 to 5.8% is the prevalence of this intrapartum related issues leading to death in the baby. So we all know that these were the series of national programs that were happening in India since WHO initiation. Like initially it was the CSSM program, then RCH1 came, RCH2 came, NRHM came, RMNCH8 plus A came, then NHM program came. But ultimately we know that all these produce a lot of change in the health scenario of India. But ultimately now what is running is India Newborn Action Plan, which aims to reduce the neonatal mortality rate to a single digit by 2030. Actually, it is a part of every newborn action plan by WHO. It aims reduction in NMR to a single digit by 2035, but we are aiming a little faster. Like maybe by 2030, we want to reduce the NMR to a single digit. So we will have to focus on three major areas. There's a preterm birth, about the infection. In preterm birth, we may not be able to do much, but in case of infection and intrapartum asphyxia related things, we can do a lot if we implement simple things. So as a part of India Newborn Action Plan, central government and of course IAP is planning to improve the birth related care that is getting to each newborn. So when we go to the 6 pillars of newborn action plan, mine is a community medicine topic, sorry for that. When we go to the 6 pillars, we can see that immediate newborn care is an important thing. Care during labor and immediate newborn care is an immediate, these are the very important 2 pillars related to NMR in Indian INAP, newborn action plan. So when they did a bottleneck analysis means after every program, they will find out those factors in which if we do simple modifications, which can have a major impact in the outcome. So bottleneck analysis were done to assess those minimal things which can produce a lot of changes in the outcome. The one important point which we have to note is the use of bag and mask at the time of neonatal gestation, which is basically help the baby breathe or basic NRP. That is the using of bag and mask is the ideal thing or the main thing in help the HBB program or basic NRP program we all do. So that was the most important part what they found in INAP, what they included in INAP to reduce NMR, which is happening due to intrapartum delivery during the delivery complications, intrapartum related problems. So implement standard protocols for intrapartum care and train the people who are attending the delivery to do basic NRP or help the baby breathing by using bag and mask. That was the main priority action that was identified by INAP during any delivery or during intrapartum period. So a few words on evolution of NRP and helping the baby breathing. So basically two are different. First NRP was published on 1987 as Sir told, but when they started implementing this NRP in developed countries itself, they could find that two things are very difficult. One thing is it is difficult to do in areas where there is not advanced units are not there. All health personnel may not be able to reproduce this NRP properly. Even after repeated cycles of training, they found that it is difficult for a health personnel to follow this NRP very perfectly. And they found that in those areas where the good setup of NIC or good setup of hospitals are not there, this proper implementation of NRP is not happening. So they thought how to solve this. That's how they came with a new idea, that is the basic NRP implementation. And NICHT study, there is a very famous study, that is a first breath study, which identified that if you apply simple NRP, that's a basic NRP, they called it helping the baby breathing. So with use of bag and mask, in the first minute of life, if the baby is not showing signs of breathing, that itself can reduce NMR or stillbirth rate by 30%. That was the result of first breath study published by NICHD in US. So they found that in low-income countries or in the units where it's not an advanced unit, where health personnel, like there may not be 3% to attend a delivery, as NRP says, in a high complicated delivery. It's not practical everywhere. So in those scenarios, if a health person is able to do at least basic NRP or helping the baby breathing module, that is the use of bag and mask in the golden minute, they have proven during using study that it can reduce the NMR by 30% or the stillbirth rate by 30%. So this is the Helping Babies Breathe launched by IAP after the NRP. They published the first baby breath study, and they found out that starting BNB, bag and mask ventilation in the first minute can produce a lot of change. Reduction in NMR, reduction in stillbirth rate. So later, this IAP was going ahead with HBBP module. It included training the basic non-physician group. They're mainly aimed at non-physician group who are attending the delivery to teach them bag and mask using mannequins and video modules and repeatedly doing it. Several cycles was happening using video and mannequins so that they will not forget to do bag and mask when a baby is not taking breath. Which is still not happening in many units in India. So later, the IL Core Committee revised NRP in 2015 or 2020 is coming, as I told. So along with NRP, this HBB is also getting modified a little bit. It is a parallel thing happening. So second edition was published in 2016, which added delayed port clamping and also along with HBB module. So HBV was analyzed in India also, because India is a low income country, low resource setting. A lot of units are there with low resource setting. So it was tried to reproduce HBV in India also. There are a lot of studies. One is there in the screen. It also could produce a decline in stillbirth rate. And also a systematic review was published by Vivek et al., which also was able to prove that it can reduce the neonatal mortality rate by some percent, like 15%. So the first message that we have to give or we have to learn is, in low income countries like India or in a country where a lot of low resource settings are there, when even in Kerala to attend a normal delivery there may not be a physician available, so a person who's trained in basic NRB or helping baby breathing, or a person who's ready to start bag and mask in the first golden minute can produce a lot of change in outcome in NMR. So that must be the priority that we should consider when we are trying to teach module in the periphery, because physician may be knowing well about bag and mask ventilation, but the non-physician who are attending, or even sometimes gynecologist may be the person, or the anesthetist may be the person who's attending the delivery in low resource settings, then or it may be a staff nurse or an NICU staff nurse or even gynec staff nurse. They should be able to initiate bag and mask without worry if a baby is not having breathing effort at birth after simple tactile stimulation. So that should be the main target that IAP or NF should aim when we are starting this action plan. Then comes the second point, that is the neonatal encephalopathy. We all know that the definition of neonatal encephalopathy is altered level consciousness, seizures, water and all. But the problem is in a periphery or in a low resource setting, when a delivery is happening, the baby received neonatal care, like they received stimulation, they received bag and mask, they received some chest compression. However, baby improved. But the next problem comes, the physician or the caretaker or the primary level care provider who is attending the delivery may not be able to identify a baby who is having encephalopathy. So if a baby with encephalopathy is not identified, they are missing the chance for getting only proven therapy of neonatal encephalopathy, that is the therapeutic hypothermia. So our second target should be, these are the different causes or risk factors that was included in my topic. That's why this slide is there. So these are the several identified risk factors for neonatal encephalopathy. It's not only the HIE, but a lot of other causes, genetic causes, metabolic causes, stroke, placental pathology, infection. So many risk factors can produce neonatal encephalopathy, and not only the HIE. That is another message that we have to give. So when the risk factors are there, the patient, the baby may require support with bag and mask or some other methods during delivery. So after delivery, after successful resuscitation, if a baby is having encephalopathy, the primary care provider should be able to identify an encephalopathy. So there are various scores or various methods to identify encephalopathy, but it's not commonly used in low resource settings, so they may not be aware of it. So there is a class by my colleague Gokul does about identifying neonatal encephalopathy, or using the score to identify various scores to identify neonatal encephalopathy, so that the primary taking the care provider can refer an encephalopathic baby to a tertiary level setup where the baby can get a therapeutic hypothermia or proper brain support care. So that's the second point. First is the initiation of bag and mask by a non-physician care person. Second point is identifying a baby with encephalopathy in the first 6 hours and trying to transport a baby to a tertiary care level so that they get proper treatment for neonatal encephalopathy. Another thing is HIE is just 30% of the cause for neonatal encephalopathy. So our gynec colleagues are having a lot of difficulty when from periphery a patient is referred with the referral letter of birth asphyxia, because that directly gives a medico-legal headache to the gynecologist, because it's written in the referral letter that it is a case of birth asphyxia, but we know that it's not intrapartum events, like it's not only sentinel events or the sudden abruption or some cord prolapse. It's not only the cause for neonatal encephalopathy. Sudden intrapartum complications are only 30% of cause for neonatal encephalopathy. So there are a lot of other causes for neonatal encephalopathy. So when you refer a baby with encephalopathy, it is better to write the diagnosis as neonatal encephalopathy to rule out causes, so that there will not be a direct medical legal implementation on our gynecologists. That was the third point which we have to stress when we are doing this initiation program in peripheries. Then, as I told, identifying encephalopathy is very important, because only proven treatment or whatever available evidence is there, only therapeutic hypothermia is giving us some hope. Others are on way. Lot of studies are happening, but still we don't have proper evidence for all those things. So TH therapeutic hypothermia only therapeutic this thing treatment that is proven with benefits. So a patient who is having encephalopathy moderate to severe should not miss a chance for that therapeutic hypothermia. So that is 6 hours is the golden period within which they should start therapeutic hypothermia. So different scores are there. We should teach peripheral persons to use those scores and identify the encephalopathy babies and refer properly to a tertiary level care center for a proper brain treatment. So another important question is whether therapeutic hypothermia is beneficial in low-income countries. A lot of debates are happening. There's a topic on that by my colleague Dr. Sreekanth, so I will not go into detail. But still, with whatever available evidence, it is said that even in the Helix trial, it is said that with a proper setup in a tertiary care setup, even with the low resource setting, even with the low tech devices like Miracradle, we can give therapeutic hypothermia, but there should be an expert person to look after or to monitor. Then it may produce good outcomes. So that is still proven to be a good therapeutic option. So we should not miss the chance to give the treatment to a baby. So my 3 points are: one is non-physician care personnel giving treatment for initiation of bag and mask ventilation in the first golden minute. Second thing is identifying encephalopathic baby a primary care provider so that they get a chance to go to higher center. Then third thing is setting at least 3 or 4 tertiary care centers where a low-tech device or a high-tech device can provide a proper therapeutic hypothermia under a supervised care in at least 3 or 4 centers in a district. Setting up that also will be an important part of our action plan. So these are the main 4 points. And the last point is referring a baby with encephalopathy as a neonatal encephalopathy without writing directly birth asphyxia and giving a chance for our gynecologists, because many of the cases it may not be a birth asphyxia proper, it may be so there may be a lot of other causes for this neonatal encephalopathy. So after workup only we can say whether it's a metabolic cause or a genetic cause or any other cause like stroke. So it is better to refer as neonatal encephalopathy for evaluation and therapy. So these are the main 4 points that I would like to stress in my topic about the current scenario in India. So I hope IAP will include these 4 points in our planning. Thank you.
Thank you, Dr. Vivek, for this presentation. If any of these kindly was in the chat box. So, early diagnosis of encephalopathy in newborn. Now we have Dr. Gokul, consultant neonatologist at Kannur, to discuss how to identify hypoxia encephalopathy in the newborn. Over Dr. Gokul. Gokul.
Yes, sir. Sharing my screen. Is it visible, sir?
Yes.
Hello.
Yes, yes.
Is my screen visible, sir?
Yes, yes.
Okay. Very good evening to one and all. Today, I will discuss regarding how to identify an HI infant after birth. So we know that there are many definitions for perinatal asphyxia, which are provided by different organizations, including WHO, which states failure to initiate and sustain breathing, and the NLPD network classified perinatal asphyxia as moderate and severe perinatal asphyxia with respect to breathing, whether it is slow gasping breathing or no breathing, and on Apgar score, whether the score is 4 to 6 at 1 minute, which is classified as moderate perinatal asphyxia, and if the score is 0 to 3 at 1 minute, it is classified as a severe perinatal asphyxia. AAP and ACOG gave different criteria, which included all of the below points. That is profound metabolic or mixed acidemia with a pH of less than 7 in umbilical cord blood, then persistence of low Apgar scores less than 3 for more than 5 minutes, and signs of neurological dysfunction with seizures, encephalopathy, tone abnormalities, and evidence of multiple organ involvement, including kidneys, lungs, liver, heart, and intestines. So why identification of encephalopathy is important? The major importance of identification of encephalopathy is its treatment that we can give. It's therapeutic hypothermia, which is the standard of care in moderate to severe HIE patients in the current scenario. And it has been proven that it can change or improve the outcome of HIE infants, even in LMIC countries. And the second would be the anticipation of complications depending upon the HIE stages. and we can proactively look for the complications that we can expect in hypoxic encephalopathy infants. Third would be the prognostication of HIE based on the scoring systems. And fourth will be for tailoring the follow-up of the infants who are having encephalopathy. So as we know that timing is everything for everyone, including especially for the neonatal care. And so when to start hypothermia, that does matters as we have to identify whether the infant is having hypoxia or not at the earliest. So in the editorial in BMJ Pediatrics, Flores Bronenthal, he concluded that we have to start hypothermia as soon as indicated. So we have to first get the indication or the criteria met before starting the cooling or the proper therapy. So we have to identify it earlier before the therapeutic window is not over. So we know that the therapeutic window that is for the secondary energy failure comes at around 6 to 8 hours of resuscitation, and we have to start the therapeutic hypothermia before that itself. So there were studies which studied whether there is any benefit of therapeutic hypothermia after 6 hours, like the late therapeutic hypothermia trial. And it was found that it may have benefit, but there is uncertainty in the effectiveness of therapeutic hypothermia after 6 hours of life for neonatal hypoxic ischemic encephalopathy. And there were concerns regarding the statistical methods used for the same trial also. So it's still in a debate whether there can be much benefit after starting therapeutic hypothermia after 6 hours of life. So we have to start at in the current scenario, we have to start it within the therapeutic window of opportunity, that is before 6 hours. So is there any benefit if we start it earlier, like before 3 hours and after 3 hours? There are mainly two studies which look into this matter. The earlier study by Thomson et al., they found that if we start therapeutic hypothermia before 3 hours of life, there could be some improvement in the neurodevelopmental outcome at 18 months of life. But in a later study, it was a retrospective cohort study by Gillard et al., they found that there is no difference in the outcome, neurodevelopmental outcome of infants who have started therapeutic hypothermia before 3 hours and after 3 hours to 6 hours, that is between 3 to 6 hours. So if we look into the in depth of this study, we can find that it's a retrospective cohort study, and we could they could find out that those infants who have started therapeutic hypothermia before 3 hours, they were having severe encephalopathy. So the end result, that is, there is no difference in the neurodevelopmental outcome as well as there is no difference in the MRI findings. That means that those infants who were started before 3 hours, they were having severe encephalopathy, and those who were started on therapeutic hypothermia after 3 hours were having lesser severity of encephalopathy. So, but the outcome was similar. So still there could be a beneficial effect if we start therapeutic hypothermia earlier. Now we will go and see the scoring methods and evidences for them. So the major one which is discussed and studied is modified Thomson scoring. It classifies infants as mild, having mild encephalopathy, moderate encephalopathy, and severe encephalopathy. So initial Thomson scoring was exhaustive, so it was modified for the ease of starting a therapeutic hypothermia and for easy criterion to make the criterion for therapeutic hypothermia. And it included if there are any three features which of among the moderate or severe group, we could classify it as having moderate to severe encephalopathy, and we could start therapeutic hypothermia for the infant. But there are other features also which have to be taken into consideration while starting hypothermia. So if you know that there is a sentinel event and we classify the infant as moderate or severe encephalopathy, that could be the time for starting therapeutic hypothermia. So what we have to do is we have to record the severity of encephalopathy each hour, so that we can find out when the patient or the infant is progressing towards moderate to severe encephalopathy. So there are the evidences for Sreekanth scoring with therapeutic hypothermia are also there, that if the score is poor, that is severe encephalopathy before 6 hours, there could be worse outcome, that is more neurodevelopmental disability. But in a later study, it was found that if the Sreekanth scoring was done at less than 6 hours alone, the sensitivity for finding out a neurodevelopmental disability is lesser, that is 42%, and with a specificity of 94%. But if we use the same staging for evaluation of the stages over the first 3 days, it will give a better prediction of the neurodevelopmental disability. So what we have to understand is that we have to do the scoring not just once. We have to follow up the infant closely in the initial 6 hours, and if we are starting therapeutic hypothermia, we have to do the scoring till the 3rd day of life for a proper usage of the Sreekanth scoring. And Sreekanth score being it's more subjective, there are some subjective factors also. So this requires training. The healthcare provider should have training in Sreekanth score for scoring it properly. The second score is a Thomson score, and it gives points for each of the abnormalities. So the total adding up added point will tell whether the infant is having mild, moderate, or severe encephalopathy. Though it is classified as mild from 5 to 10, and moderate from 10 to 14, and severe as 15 and above, there are differences of opinion, and the correlation with Sreekanth scoring and Thomson scoring are also made, which was showing that mild will be having 4 to 6, and moderate from 7 to 13, and severe from above 13, like that also. So the Thomson scoring includes tone, loss of consciousness, seizures, posture, moro, grasp reflex, suck reflex, respiration, and anterior frontal. Then coming to the evidences for Thomson scoring, it's more objective as we are giving points. If we are trying to make a subjective one to more objective one by giving points. And it is used in many trials for therapeutic hypothermia, and it is still being used as a criterion for initiation of therapeutic hypothermia, especially in countries like Netherlands. And we know that it can predict outcome at 4 to 5 years, even with therapeutic hypothermia. And a score of less than 10 is associated with a normal cognitive, could be associated with a normal cognitive function. And it's a good prognostic tool, especially for the short-term outcomes of HAE. And if there is higher, if the infant is having higher score, there is more chance for death before discharge, epilepsy, and severely abnormal amplitude integrated EEG. And a severe Thomson score more than 15 has got a positive predictive value of 92%, NPV of 82%, sensitivity of 71, and specificity of 96% for abnormal outcome at 12 months of age. And if the infant is improving his or her Thomson score during the first week, that gives a better outcome for the infant. And it was found that the interrater reliability is very good, and Thomson score may not need specific training to do. The next one that we can routinely do would be Levine's classification. It's a more simplified version, and it includes consciousness, tone, seizures, whether the infant can do sucking or respiration, or how is the respiration of the infant. So this is more a simplified version of encephalopathy staging. Another scoring has been given by Simon. That's a score of Ibero-American Society of Neonatology, which classified the infant as having mild encephalopathy, moderate encephalopathy, and severe encephalopathy based on the scoring. The major factors are the level of consciousness, spontaneous activity, posture, tone, the Moro reflex, then pupils, how the reaction of the pupils are, then heart rate, breathing, and seizures. So the advantage of Cyban is it can be started immediately after delivery room resuscitation, and it was proposed for diagnosing the infants having HIE in the delivery room itself. So it can recognize the mild encephalopathy because it is it includes the 40% of the HIE presentations. And all 3 grades of neonatal encephalopathy can be diagnosed in the first 6 hours of life with Cyban. And criteria for HIE is 3 or more features of the Cyban scoring in each mild, moderate, or severe. Then now with the different scoring systems, and we will have a confusion which one to be used for identifying encephalopathy. We can use any standard scoring system, and the criteria for therapeutic hypothermia were done by different systems, including modified Kannur scoring, then Thomson scoring, and Cyban scoring. But more importantly, whichever scoring that we are using, we have to follow it up, and we have to make sure that we are not losing the window of opportunity to give the treatment for treatment as a therapeutic hypothermia for the infant. So whichever scoring that we are using, we have to follow the infant in the initial period till 6 hours, whether to identify whether the baby needs therapeutic hypothermia, and later we have to follow it up so that we can identify the prognosis of the infant. Thank you all.
So, our next speaker is Dr. Sreekanth. Sreekanth? Sreekanth?
Yes, sir. Yes, sir. Can you see the slide, sir?
Coming.
Yeah.
Not yet came.
Can you see the slides?
No. Not now.
Yeah. Can you see, sir?
Slides.
Slides. Can you see my slide?
Oh no. Just click on the share the slide.
Yeah. I'll just click.
Share screen.
Share screen, yeah.
Yeah. Now.
Share screen, then click that share.
Yeah. Can you make me a host?
Irshad, make Sreekanth co-host. Irshad.
Sir, he's already a co-host.
Co-host. Then you can do, Sreekanth. You just click that green button, share screen.
Yeah.
Then after that blue button, share. Then your desktop window will come there. And then open that slides. That's it.
Yeah. Can you see?
Yeah, no. Share. You are sharing screen. That's not coming. Yeah. The desktop is visible now.
And open it. Oh, yeah.
The last slide came. Yeah.
Yeah, now you can see.
Yeah.
Yeah.
And you have to increase your voice is not clear.
Yeah. Now? Am I audible?
It is not loud enough. I think you can keep your microphone little closer.
Hello, Dr. Sreekanth. If you have two mics on at the same time, there will be echoes. So if you are logged in with the second device, you can switch it off, or you have to take it into another room.
Unmute.
You make it full screen, Sreekanth. Slide show. Yeah, now it's okay.
Yes.
Yeah, it's okay. You can start, Sreekanth.
Hello.
Yeah, your slides are visible, but voice is not coming.
Mute. Unmute. Hello.
Sreekanth.
Panna. Okay. Okay.
Yeah. Can you hear?
What the? 190. ചെയ്തോ എൻ്റെ സൈഡിൽ നോക്കി വൈറ്റമിൻ കെ എത്ര 1 mg 2 mg എടുത്തു
Sreekanth, yeah, now
വേണ്ടി വരും ചിലപ്പോൾ വേണ്ടി വന്നാൽ പറയുന്നുണ്ടെങ്കിൽ
you make it full screen.
Yeah.
And you keep your microphone little closer to, because your sound is not so audible. Again has gone.
Can you?
Sreekanth,
Yeah. Yes, sir.
it's gone. Your slides are not seen now. You just start again. You share it. Yeah, it's okay. Then open your presentation.
Yeah. Now.
No, it's open your. Yeah, now it's okay. You can start. You can start.
Yeah. Okay. So, therapeutic hypothermia has found its application in various fields of medicine. It's like from post-cardiac arrest in adults, post-arrest in pediatrics. Decades of studies in animal modes have found relation to asphyxia. The first and foremost, the therapeutic hypothermia altogether started from an animal data. It all started as there was studies then that cooling needs to be started within 6 hours. Why the 6 hours is and earlier the better. The studies have found out that the 6 hours is the time when all those mechanisms where the free radical or the liquid peroxidases, all those injury starts occurring, and the neurotransmitter, all those being released, and causes neuronal apoptosis. And there are a lot of other mechanisms. So the brain needs to be cooled at a temperature of 32 to 34 degree. And prolonging the duration of hypothermia improves the neuroprotection. So what is in brief, the mechanism of hypothermia? The hypothermia, the basic mechanism is to reduce the cerebral metabolism to 5 to 7%, so that by 1% reduction in the body temperature, the cerebral metabolism is reduced to 5 to 7%. So the anticonvulsant properties by inhibiting the glutamate, anti-inflammatory, then anti-apoptotic. These are the mechanism of hypothermia which prevents neuronal apoptosis or neuronal cell death by anti-inflammatory, anti-apoptotic, and anti-convulsive, all those properties. So there are a lot of mechanisms. This is a long question for our exam. So, I mean, I won't bore all with the mechanism. Just basic funda is that it reduces the cerebral metabolism, reduces the energy use, reduces the free radical generation, and basically it prevents, attenuates the secondary energy failure and attenuates the apoptosis and necrosis and reduces the brain injury. So therapeutic hypothermia, there are multiple RCTs which has done, investigated the use of induced hypothermia for newborns with neonatal encephalopathy, has led this therapeutic hypothermia becoming a standard treatment for newborns from 36 weeks of gestation or greater with neonatal encephalopathy related to intrapartum hypoxic events. So what are the evidence of cooling in newborns? There are 11 RCT and it's comprising of 1505 term and late midterm in moderate or severe encephalopathy. This is a moderate and severe encephalopathy, which my colleague has already spoken, is the one which we cool these newborns. This is a forest plot which is showing that the one which is in the middle, the one which is showing is the one favors, the one in the right does not favor. So all these studies, these are the forest plot depicting these studies, the cool cap, the zoo, and National Institute of Child, TOBI trial, IC trial. All these trials, these are all favors the therapeutic hypothermia. So therapeutic hypothermia result in improvement of primary outcome of less death and better neurodevelopmental outcome for the survivors. And 8 out of 11 studies demonstrated that therapeutic hypothermia decreased the combined outcome of mortality of major neurodevelopmental disability by 18 months. And the number need to treat is 7. So you have to treat 7 for one neonate to benefit, and for these newborn to demonstrate a decreased mortality or major neurodevelopmental outcome by 18 months of age. These all data are Western data. So what are the advantage of therapeutic hypothermia? So the one which is on the left of the first book, which favors hypothermia, it reduces death, severe disability, cerebral palsy, and psychomotor delay of less than 70, and mental developmental index of less than blind. Everything is reduced with this, which favors hypothermia. So what are the secondary outcomes? So and how feasible it is? So there are 11 more studies which has shown it has reduced the mortality, and 8 studies demonstrated that therapeutic hypothermia decreases the neurodevelopmental disability in infants who survive, and the number need to treat is 8. And based on all available RCTs, hypothermia, therapeutic hypothermia seems to increase survival without increasing major disability in survivors. So these are all the Western data, so the cool cap, the National Institute of Child Health study, the TOBI trial. These are all, the TOBI has found a significant improvement in the secondary outcome, though the primary may not, but the other 2 studies have shown the beneficial outcomes. So I'll be talking about not much of this thing on TOBI trial. Simply to summarize, see, it was done for the asphyxiated moderate severe encephalopathic infants. All those studies, they have shown that it has reduced reduces the disability. At 6 to 7 years of age, those child who have received hypothermia, they have had higher frequency of survival, better IQ of 85 or higher compared to children who was not cool. So cooling and not cooling. So the difference is very evident in the Stobie trial. So the children of the percentage of children who died in this were 30% were similar in all the cool or non-cool. Among the children who survived, the normal neurological outcome were more common in the hypothermia group when compared to the control group. So, and the risk of CP also is lower in the one who is cooled than in the non-cool group. So, what are the indications? Whom to cool? More than 36 weeks, less than 6 hours of life. If you get a newborn, with if you can demonstrate a pH within 1 hour, which is unfortunately we don't have this facility in majority of the peripheries or in the some of. If we can demonstrate that a baby has got a pH of 7 or less, there's some has got 7.1, 7 or less, and the base deficit of 16 millimoles per liter in a sample of umbilical cord or a sample
Sreekanth.
Mute అయిపోయా.
Hello, Sreekanth. Sreekanth, you are not audible. Sreekanth. Sreekanth.
Connection issues. Call on mobile. Oh.
Hello, Sreekanth, you are not audible. Phone is also switched off. That's the issue. Hello.
Might be network issue.
Sreekanth out ആയിട്ടല്ലേ?
Sreekanth ഇല്ല.
ഒക്കെ പോയാന്തോ?
അത് കണക്ഷൻ
ഒന്ന് വിളിച്ചു നോക്കോ?
ഞാൻ വിളിച്ചു. ഫോൺ സ്വിച്ച് ഓഫ് ആ, ഫോൺ എടുക്കുന്നില്ല. Prashant.
Sir.
Prashant, I think we'll continue with the discussion. I think it's already 9:15.
What about the doubts, audience?
So any doubt? I can see so many experts on the platform. Dr. Binish is there, Jayakumar sir is there, Dr. Ambili. So Dr. Ravindra Verma is there. Now I could not see him. Dr. Balachandra is there. I think you can share your experience. Dr. Balachandra.
Just one doubt. What can be the rationale behind the 36 weeks inclusion criteria for HI cooling? Inclusion criteria 36 weeks and above. Is there anything? Will it do anything harm if we subject a 33 or 34 weeker to cooling? If it satisfies other criteria?
Gokul.
There are actually lesser evidence. Like there are studies with 35 weeks also included, especially one study from China. They have included 35 weeker infants also, and they were having from all the criteria that we are having right now are from the trials. So there were trials with infants including 32 weeks who were cooled, but with having lesser number of participants. All initial like 32 to 33 weeks, then 33 to 34 weeks, and 34 weeks and 34, 35 weeks also. Like this, they have stratified and done studies. But there was little evidence to suggest hypothermia for these infants. So with lack of evidence, right now we cannot suggest hypothermia for these infants. And we know that if there is a higher chance for deeper hypothermia, or there are the side effects caused by, or the complications of therapeutic hypothermia will be higher in these infants. So as they have got other issues also, like the maturity of the pulmonary vasculature. So there would be, we are expecting more studies in this cohort, following which only we can suggest hypothermia for these infants. So as of now, we have evidence for 35 weeks and above for starting hypothermia. Below that, we still need enough evidence to have or to start hypothermia as a standard of care for the infants less than 35.
One question in chat box. Dr. John has asked minimum weight which we can include for cooling.
As of now,
Gokul, your audio is not
includes,
also very audible. You got the audio, I think. The audio is not audible clearly.
Hello, sir. Is it clear now?
Yeah. Disturbance is kindly, others kindly mute.
So now the criteria is more than 1,000.
Others kindly mute, please.
As of now, the criteria is weight of more than 1,800 grams. So.
Then I have one doubt.
There are some studies saying 2 kg also. Many of the studies have included 2 kg also.
Yes, sir. 1,800. At least 1,800 grams should be there.
Yes.
So I have one doubt, Dr. Gokul. There are so many scoring systems like modified scoring, Thomson score, and Levine score. So which one you are using, and which one you advise for a pediatrician working at level 1 and level 2 care center?
The easiest one to use right now would be modified Sarnath scoring, because it will give the definite criteria for starting therapeutic hypothermia. The major trials have used this same scoring system for starting therapeutic hypothermia. So if the infant is having 3 or more features, including the moderate or severe encephalopathy, that tells that the patient is having moderate to severe encephalopathy. And at that point, if other points are also there which are met, then we can start therapeutic hypothermia. So I would suggest we can do Sarnath scoring, but only this would be there should be some training in Sarnath scoring because it's more subjective. So it's the choice of the institution for the pediatrician to use which score. As Thomson scoring is also good, I cannot suggest that this score should be used by everyone, because Thomson score is also good and it has also shown to have prognostic value, and it is more objective. Like we can see the scoring from 1 to 22 and grade whether the patient is worsening or improving. That we can see with the Thomson score. And mainly, even whichever score that we use, we have to be using it on the follow-up also. Like in the initial 6 hours, we have to repeatedly do this. So to identify the patient is going for moderate or severe encephalopathy. And if we are starting therapeutic hypothermia, we have to use this at least for the 3 days so that we can at least give some prognostic value for this scoring also.
During the monitoring, during the therapeutic hypothermia, when the nurses are monitoring the baby, they find it very easy to use Thomson score to assess the baby because it's not that subjective. So for the nurses monitoring therapeutic hypothermia, it may be easy for them to use Thomson score rather than Sernat score. Sernat score may be more easy for the doctors to use, I think.
Yeah, it needs
Dr.
some
Vivek,
training.
Dr. Vivek, it is for a common man, it's very simple to hear that therapeutic hypothermia. But I think it is not a simple procedure, and it's a lot of complications during, especially during rewarming. So kindly tell what are the complications and issues associated with therapeutic hypothermia. Anyone can take question. Vivek or yeah, Dr. Vivek.
Actually, first thing itself is the NICU stay that we have to say, because for 72 hours, definitely it is a NICU stay. We have to tell them NICU stay is there, the cost involved. Second thing is the outcome. About the outcome also, what I can see is it is a reduction from 60 to 45 relative risk or percentage, if you say, but that is may not be a final answer for our baby. Number needed to treat is 7. So if you do 7 pooling only, sometimes we may get a benefit. That is there when you see the result. So when we explain a parent, it is very difficult to promise that this therapeutic hypothermia will produce marvelous changes in your baby. So first thing is the effectiveness of cooling. So that we have to first tell them in detail how much effect it may produce and how much complication it can produce. That is the first difficult task. And also long NICU stay, because 72 hours you will be in cooling therapy, then slowly rewarming, then watching for the complication. So it's getting prolonged. So the long therapeutic stay, the long hospital stay, the cost involved, and then about the outcome that may be good or may not be good, only a minor difference it may make. So all those things to explain a parent, it may be difficult. Then we have to explain about the pulmonary hypertension that can happen, prolonged ventilation, coagulopathy, risk for IC bleed, sepsis, thrombocytopenia, need for transfusion, sudden stoppage of therapeutic hypothermia due to severe shock, refractory shock. So many complications are also expected. So when we explain these many complications and a possible good outcome, many of the parents say, is it needed or not? It is very difficult for them also to decide.
Then what about equipment required for therapeutic hypothermia? Is it costly or it is cheaper? Can any small hospital in any town can afford it? If at all they are trained in.
Yes, actually Miracradle, the low tech device is not that costly because it is available in Delhi markets for 1.7 lakhs. But the problem is, for doing that, we may have to put an intra-arterial line to monitor BP closely. So you need an intra-arterial BP monitoring. You need that expertise. If patient develops complication, you will have to have ventilator and all those specific things to manage the baby. So it's not easy to start in a low resource setting. It can be done only tertiary level setting as per latest evidence, because low income country, they say only in resource rich settings you can try low tech devices. It may be catastrophic if you try therapeutic hypothermia using low tech devices in low resource settings. So it is not easy to set.
So what about the ideal cooling equipment?
It will be the Ticotherm, which cost almost 13 lakhs. It's not possible for us every unit to buy a Ticotherm. It's very difficult.
Another thing is the identification and transportation.
Is the rewarming process easy with the Ticotherm? Rewarming is easy with the Ticotherm?
It is programmed. It is programmed.
Programmed, yeah.
But with Miracradle, rewarming is really difficult.
Yeah, it's manual.
That will include more nursing.
Really difficult. That 6 hours is too difficult.
Like
one question is there in chat box. Dr. Basil Tile asked, any recent evidence of cooling in milder encephalopathy? Any indication for milder baby with a mild encephalopathy?
Not yet, I believe. Gokul.
Actually, there are evidence. There were studies which included mild mild encephalopathy infants also. But there is definitely lack of short-term as well as long-term effects of hypothermia in these infants. Though we have got plenty of evidence that mild hypothermia itself also can lead to neurodevelopmental disabilities in children, which may be from learning disabilities on. So the need of there is need of our to have enough weighted studies in this regard, like for cooling mild hypothermia. As of now, we cannot recommend cooling mild hypothermia, mild encephalopathic infants because there is the lack of short-term as well as long-term evidence, because there could be more complications also associated with hypothermia. It's not a complication or side treatment. So we have to have definite evidences. So after that only we can recommend it for routine.
18 months results are not available. 18 months results are not available.
I think take-home message is hypothermia, therapeutic hypothermia is not a simple process as it spells, because it involves a lot of close monitoring and a lot of adverse effects. I have seen this subcutaneous fat necrosis is 2 or 3 babies I have seen, and hypercalcemia, even nephrocalcinosis following all these things. So I think you have to be very careful while talking about therapeutic hypothermia, because it spells very simple. Because
monitoring should be really
case selection. Yeah, case selection is very important, and monitoring is very, very, very important. What about feeding the child on therapeutic hypothermia during warming and rewarming? This thing.
There are
and rewarming process.
Feeding. There are institutes which follow feeding of the infants who are already on therapeutic hypothermia. Like if the infant is in hemodynamically stable, that the baby is not requiring additional inotropes, or if with the baby being stable, we can usually start at least minimal enteral nutrition on day 1 itself, and we can increase it slowly, and we can even make the infants full feeds. This after therapeutic hypothermia is over, we can make the baby on full feeds within the next 24 to 48 hours itself. So we can start minimal enteral nutrition because it has got its own advantage for the infant. But it has not been shown to increase necrotizing enterocolitis in infants who are undergoing therapeutic hypothermia if we start on minimal enteral nutrition. Many centers are routinely starting feeding if the baby is having hemodynamically stable status.
What's your opinion about passive cooling? Passive cooling.
Passive cooling has been shown to induce cooling, but the problem is it could lead to deeper cooling, or the babies can go in for very low temperatures, and it is actually very difficult to make the baby in the strict temperature line or the within the target. So passive cooling can be done, and there are studies with passive cooling also, and it can also be done, but it will be of greater nursing care will be required. Nurse intensive care will be required for the passive cooling, but it can still cool the infant to lower level. So
Vivek, will you recommend?
No, we will not recommend passive cooling right now.
Sir, during transport, I may recommend. If you are transporting the baby to a therapeutic hypothermia center, on the way, I may recommend a passive cooling. Otherwise, no.
In the form of, what advice will you give them? What advice will you give them? The case is coming from, I think, from Kannur, case is referring to you, and they are called. What advice will you give them? What are the things you have to be take care while transporting a child? Asphyxiate a child from, suppose from Kannur to Kannur. What advice will you give?
Definitely avoiding hyperthermia, maintaining oxygenation, perfusion, sugar, brain protective 4 measures, very important. Then if you are sure that it's a moderate to severe encephalopathy and you are transporting to a center where cooling is happening, you may opt for passive cooling without using any like embrace or anything to keep the baby very warm. In that scenario, I may recommend a passive cooling.
Dr. Sreekanth.
I think Gokul is not agreeing with that. Gokul, please.
Yeah, I will not start with passive cooling on transport because first we have to make sure that the infant is having a normal hemodynamic status. That is important. So just before starting or before the infant is satisfying the moderate to severe encephalopathic criteria, we are not supposed to keep the babies in hypothermia. So unless the baby is diagnosed to have moderate to severe encephalopathy, it may be dangerous to have severe hypothermia for the infant because passive cooling, we don't know how at what level the baby will be cooled. So if we can maintain the temperature or we can continuously monitor the temperature, in that case we can consider passive cooling. Otherwise, it may be making more harm for the infant.
So that was the introductory sentence. If you are sure that it's a moderate to severe hypothermia, if you can maintain 4 brain protective therapy things, then you can. That's it. See.
Then what about usage of prophylactic anti-epileptic and prophylactic antibiotics in a child, asphyxiated child while transfer in the primary care center? Will they advise to you advise or even are you giving prophylactic antibiotics and prophylactic anti-epileptic drugs in asphyxiated child?
No, sir. Prophylactic antibiotics and anti-epileptics are not indicated in infants with hypoxic encephalopathy unless they are having definite risk factors for sepsis. If they are having definite risk factors for sepsis, we know that it will be difficult for us to identify the clinical features of sepsis when the baby is on therapy hypothermia. So if we have got risk of sepsis, yes, we have to start on antibiotics. But if there are no risk factors, we are not supposed to start antibiotics because we know that if we start antibiotics unnecessarily, it itself is a risk factor for mortality. So we will not start antibiotics for a baby who is not having any risk factors for sepsis. And anti-epileptics, yes, we will not start unless there is seizures. So though the seizures may not be clinical seizures, but it can be EEG seizures also. And it was shown that you can treat EEG seizures also without having any clinical features, and it may also improve the outcome of the infant. But the usage of anti-epileptics as an empirical measure is not recommended.
I think we have 1 or 2 queries in the chat box. One is like, is there any evidence is there indication to use therapeutic hypothermia more than 72 hours?
No role.
No role, yeah. And another one, Dr. Binish Balajana, in the light of helix trial results, it's now important that only those centers which have good monitoring and follow-up services should start therapeutic hypothermia. Passive cooling as of now, I am not. Feeding is perfectly okay. That's just a comment. Yeah.
Passive cooling is not recommended.
And not recommended. Yeah.
Not recommended. And ideally, if you anticipate a moderate, if you have a case like what we do is we resuscitate the baby, we off the radiant warmer, and we in-house asphyxia. I had in my in-house asphyxia on the first month when I joined Aster. For that baby, I had to cool, and that baby was now the baby is now 2.5 years old. The baby had seizures at 4 hours of life. Baby had continuous seizure around 24 hours. But the baby had to give phenobarbital and levetiracetam. And as and when the baby's neurological status improved, we could stop the baby's epileptics, and the baby is now doing pretty fine. And therapeutic hypothermia should be done in a center where you have a level 3 neonatal setup, where you can monitor the invasive BP, or you can monitor the perfusion, can monitor if there is any end organ injury, all those things you should ideally monitor, and you should have ideally 1:1 nursing, and where you have the facilities to even to ventilate. Ideally, it should not be done at a peripheral hospital.
What can be done for the temperature fluctuations due to the frequent meconium staining while doing in meracradle?
Yeah.
Rectal thermometer, frequently it will be meconium stained and the temperature fluctuations will be there.
Yeah.
And for that, what can be done? Anything?
We have a, we can either, we have a, we can attach that probe on the abdomen, and we can, or we can monitor.
Skin and this one. Okay.
Yeah.
Sreekanth, what about your follow-up case? What you have
we had
for past 2 years?
bad,
yeah. What is your
we
experience
had
with hypothermia?
7 cases, I think, sir. I think 5 or 7 cases. One bad subcutaneous fat necrosis. I mean, in that the 3 of them are doing pretty fine. The one with the severe HIE, that baby unfortunately lost to follow-up. They had come up to 1 year of age. Then we could not follow up that patient. They were somewhere near to Nadapuram area. Very difficult to convince the bystanders. But others, what we had, all of these cases as of now, they are doing pretty fine, except one has got slight isolated motor delay. Other than that, there is no sensory neural hearing loss or no other sorts of sequelae. And this first example, what my boss used to teach is the first one and only example. What is is Lord Krishna. Lord Krishna was born on the river of Ganga. He was born asphyxiated. He was a standing example of therapeutic hypothermia, because he was born asphyxiated. He was transported from the transport across River Ganga naked. And he was having cyanotic heart disease, and he had lived up to, I think, more than 100 years. So my sir always used to say, the first and the therapeutic hypothermia does have a lot of beneficial effect, provided you should have adequate facilities to monitor it. It is, I'm not telling it is difficult, but we should have ideally ways to monitor and do what next.
So last word from you for practicing pediatrician in a peripheral hospital. So how to early, 2 or 3 sentences. Early diagnosis, what is the importance of early diagnosis and transport? How to transport? That's the most important one. Because late shifting and the issues during transportation, that is the big headache. The outcome decides. So I think, what is your comment? That is your request or advice to pediatricians practicing our periphery regarding early diagnosis and early shift, the initial care, primary care of the asphyxiated baby.
Sir, first and foremost is to identifying HIE baby. Identifying all these babies, it should be ideally we should be ideally creating more awareness among the peripheral pediatricians, practicing pediatrician, whom to refer, whom not to refer, and it should be referred, and ideally within the first 6 hours, that period, because there are a lot of other centers where the baby has come at 6.5 hours. We do cool, but there's not like we don't cool, because considering the fact that the long-term outcomes, the beneficial effect of this in the Western data and the Helix trial and the Thin study, all those things, it has shown, the Helix trial, although has got not shown much, it has shown that it has not shown much of a difference. What we should do is that, considering the fact that the neurodevelopmental outcome is better when you cool babies, when you cool the babies and who is not cool. So that should be emphasized, and they should be ideally transported. We do have, I think, Koili and Kannur, we have a neonatal transport unit. We reach out to the hospitals once we get the call within a span of 1 hour or 2 hours, and we do transport. I myself transport many babies, and we have transported many like that. Our team is well equipped in transporting many from the centers, so there's no much headache for the peripheral pediatricians.
So I think time is already 9:40. There are no more questions. We'll wind up the session. Oh, thank you very much, Dr. Vivek, Dr. Sreekanth, and Dr. Gokul for a very good discussion and elaborating the importance of the early diagnosis of perinatal asphyxia and encephalopathy. Thank you very much. We are handovering the mic to our organizers.
Now, the vote of thanks by our secretary, Dr. Ishad.
It's my privilege to express vote of thanks on behalf of IAP Kannur. First of all, thank Dr. Padmanabh Shanai, Honorable President IAP Kannur, for welcome address and also for deciding the meeting. Thank you, sir. I thank Dr. P. Jayaraman, sir, Honorable President IAP Kannur, for inaugurating as well as for the wonderful presidential action plan progresses. The beauty of the topic strategies to prevent and reduce perinatal asphyxia is if we can prevent perinatal asphyxia, it will change the fate of that baby. Thank you, sir. I also thank Dr. Joni Sebastian, Honorable Secretary IAP Kerala, Dr. Narayanan, sir, Immediate Past President IAP Kerala, and Dr. Nihaz, Chairman, Presidential Action Plan Strategies to Prevent Perinatal Asphyxia. Thank you all. I also thank our speakers, Dr. Vivek Raju, Dr. Gokul and Dr. Sreekanth, sir, for an excellent academic piece. Thank you all. Also thank Dr. Nandakumar, sir, and Dr. Prashant, sir, for moderating the session, and each and every one of you for attending and making this program a grand success. I regret for some technical issues. Thank you all. Good night. Baba Samsar.